So thank you, Dr. Bhavesh, for the nice word. So it's always nice to present physically. The last 1.5 years, all of us were sitting in front of the computer and presenting with the webinars. So I'm sure this will be a big change, and that is the need of the hour as well. So today we have got a very interesting talk, a bit of a big task actually. It's a very big chapter. So as Madam has highlighted and Dr. N.K. Singh is coming next, so we have an interesting session to be discussed. I am trying to make it bit simple, which should be clinically useful to our day-to-day practice. So measurement of CV risk in Indian type 2 diabetes patients. So first of all, greetings from Bangalore. So this will be the overview of my presentation. So if you take the introduction, the patients with type 2 diabetes have a 2 to 4-fold increased risk for cardiovascular disease, and CVD remains the leading cause of death among diabetes patients. Although it is now widely accepted that diabetes is not a CVD equivalent, but there is a heterogeneous group with wide spectrum of CVD risk. Reliable and accurate assessment of CVD risk remains always a problem. So if you take CV risk measurement, why it is needed? That is an important question. So initially, diabetes was considered as a coronary heart disease risk equivalent. So, but evolving evidence suggests, so you can see this meta-analysis, which include 13 cohort studies. It indicated that at least in some groups in diabetes population have much less risk than we thought before. Another study, that is coronary artery disk risk equivalence in diabetes, depends on the concomitant risk factors. So this is a data from United States National Health and Nutritional Examination Survey, also showed that 32% of the men and 48% of the women with diabetes were actually at low risk to intermediate risk according to the Framingham risk score. So heterogeneity always exists with respect to CVD risk in diabetes on the basis of other coexisting CVD risk factors. So hence refining risk estimates in diabetes patients may help to implement prevention strategies in an efficient and cost-saving manner, as well as reducing the potential side effects of preventive therapies if not needed. So how to stratify cardiovascular risk in diabetes? According to the association, one is the American Heart Association and American College of Cardiology approach. The second one is the ADA approach. So if you take the American Heart Association and American College of Cardiology approach, the panel considers that patients with diabetes, either type 1 or type 2, aged between 40 and 75 years, who have a baseline non-treated LDL between 70 and 189, should be stratified into a higher or lower risk category to receive either high or moderate intensity treatment with statins. The panel defines high intensity treatment as the statin therapy able to reduce the LDL more than 50% from the baseline. Moderate intensity treatment is defined as the reduction of LDL in about 30 to 50%. So if you take the ADA approach, ADA recommends risk stratification including 3 variables: the age, the existing of previous cardiovascular events, and the presence or not of risk factors. ADA risk factor, what are they? LDL above 100, high blood pressure, smoking, overweight, obesity, and family history of premature ASCVD. So how to identify the high risk patient? It's always a challenge. The first, you take age, that is the commonest one. The age is the strongest non-modifiable risk factor for CVD. The increase in cardiovascular risk is continuous and progressive either in men or women. However, a transition to a high-risk category for developing cardiovascular disease seems to occur at a definite age for each gender. So you can see this study shows that the relationship between age and cardiovascular disease in men and women with diabetes compared with the non-diabetic population, non-diabetic people, it's a population-based retrospective cohort study. Coming to the gender, In this meta-analysis of 37 studies, what it shows, women with diabetes, the relative risk for a fatal coronary event is 50% higher than in men. That is what Dr. Shailaja was telling in her presentation. So the gender has not to be neglected, especially females, has to be given equally important. So this was probably explained by a less favorable cardiovascular risk profile in women linked to hypertension and hyperlipidemia. The presumed reduced likelihood of women receiving the standard treatment for acute coronary syndrome and cardiovascular prevention is also important. So thus, women with diabetes seem to lose the protection due to gender, greatly increasing the incidence of CHD in relation to men and with greater mortality due to AMI. So the next important aspect is the family history of coronary heart disease. This has to be taken very seriously and it has to be addressed very early in the management of diabetes. So AHAACC guidelines recommend to consider family history of premature coronary heart disease as a major risk factor defined as a male less than 55 years and a female less than 65 years in any first degree relatives. Another important aspect is the smoking. This is you can see this meta-analysis. What does it say is active smoking was associated with more than 50% increase in mortality and CV events in compared to non-smokers. However, former smokers, those who have left the smoking, were also at a higher risk of mortality and CVD events than the never smokers. Another important aspect, these are the factors what I'm going to tell, these are the things where the risk stratification has to be done. The important aspect is hypertension. As all we know, hypertension has to be controlled aggressively from the beginning. This is another meta-analysis from 40 trials. What they say is reduction of 10 millimeter of systolic blood pressure reduced mortality, cardiovascular events, coronary artery disease, and as well as stroke. So body lipids, the LDL-C is one of the most important reversible risk factors for cardiovascular morbidity and mortality. It has to be addressed very aggressively either with a high intensity statin or the moderate intensity statins. So simple thing, if you take what are the clinical features suggesting diabetes patients at high risk, if you take, these are the few points: diabetes and age more than 60 years, diabetes and microalbuminuria, diabetes and moderate or severe chronic kidney disease, diabetes and previous diagnosis of familial hypercholesterolemia, diabetic with high systolic blood pressure, and diabetes with high cholesterol. These are the factors to be taken seriously. ADA guidelines on stress testing in diabetes patient, atypical or typical cardiac symptoms, resting electrocardiogram suggesting of ischemia or infarction, peripheral or carotid occlusive arterial disease. So coming to an important aspect, like you may ask, what are the biomarkers to say the person is going to develop cardiovascular disease? So these are the various biomarkers. One is the HSCRP, which can be done in our routine clinical practice. The second one is the coronary artery calcium score, carotid intima media thickness, ankle brachial index, and lipoprotein associated phospholipase A2. So HSCRP is a marker of a systemic inflammation and a predictor of incident CVD and CHD independent of diabetes. Various studies has confirmed that HSCRP is independently associated with an incident of CHD, adding information to the traditional risk factors of Framingham risk score. So you can see this pooled analysis of nearly 26,000 patients where CRP was associated with 54% increase in cardiovascular death and 53% greater risk of all-cause mortality across subgroups of participants. So basically, simply by doing HSCRP, you can do wonders in the management of diabetes. Another prognostic implications of the biomarkers, you can see on the top there, the various biomarkers reflecting the pathophysiological process of myocardial injury, that is with high sensitivity troponin T, hemodynamic stress with N-terminal pro-B type, that is BNP, and inflammation with hsCRP. What does this analysis say, which nearly 12,000 patients were involved in? The elevated levels of troponin T, pro-BNP, and hsCRP improved discrimination and correct reclassification of the risk for the primary endpoint, the individual endpoints, and the hospitalization for heart failure. Coronary artery calcium score, Dr. Shailaja Madam has detailedly discussed about this important aspect which has to be done regularly. You can see this here, this is another meta-analysis showing the usefulness of coronary artery calcium score. This meta-analysis indicated a linear relationship between the coronary calcium score and the CHD events. Another important aspect is the carotid intima media thickness and the carotid plaque. I'm sure all of you know about this carotid intima media thickness. The bottom line you can see here, increased CIMT, that is the carotid intima media thickness above 1 millimeter, is also predictive for CHD in younger individual without previous cardiovascular events. So the usefulness of carotid plaque in combination with intima media thickness for the detection of coronary artery disease in an asymptomatic patients with diabetes, you can see this seems to be an independent of age, hypertension, hyperlipidemia, and HbA1c. Another simple test which we can do in our clinical practice is the ankle brachial index. A low ankle brachial score is associated with a higher CVD risk. So this is one study, it's a Chinese study which has shown ABA less than 0.9 was independently associated with high risk of all-cause mortality and CVD mortality. In this study, they showed decreasing ABI scores below 0.9 presented a progressive association with mortality. Another important aspect is the lipoprotein associated phospholipase A2. This is one thing, it's an inflammatory biomarker involved in the atherogenesis, particularly in plaque rupture. So measuring of this shows the activity and mass. One cohort study examining LPPLA2 and incident CHD in type 2 diabetes patient found that LPPLA2 activity was associated independently with total CHD and heart CHD. Although several currently used drugs, especially statins, beta blockers, and aspirin, may reduce these LPPL2 levels, but none of them specifically target this particular molecule, particular lipoprotein-associated phospholipase. Two important scores which you can get it online. You can do it very easily sitting at your clinic, is the Q-risk score. Q-risk score, it is an algorithm for predicting cardiovascular risk. It estimates the risk of a person developing cardiovascular disease over the next years and 10 years and can be applied for those aged between 35 and 74 years. So this is a very simple score which you can get online and you just have to fill and see the risks for that particular patient. Another score is the JBS3 score for CVD risk estimation. It's the major focus of this GBS3 report is the idea of estimating cardiovascular disease risk over a lifetime to inform prevention strategy with lifestyle changes and whenever necessary the drug therapy as well. So if you take the choice of investigations for risk stratification in diabetic patients with suspected CVD, you can see this there, the various tests are there and their sensitivity and specificity, like whether it may be exercise stress test, stress echo, stress nuclear perfusion scan, CT angiogram, and coronary calcium score. Another sensitivity and specificity of provocative test, especially in women, you can see the exercise ECG, exercise echocardiogram, pharmacological echocardiogram, nuclear perfusion study, and the CT coronary angiogram. So this is a simple flow chart. It looks simple, but this is where if you use this in your clinic, you can keep a flow chart in your clinic where you can use it in how to assess, how to go about. You can see here on the left-hand side the cardiac risk score. you can use either UKPDS, advanced, and Fremantle. History and examination is the very vital in our clinical practice. If the person is having the symptoms of cardiac events like shortness of breath or exercise intolerance, chest pain or claudication, erectile dysfunction, never to forget, resting tachycardia and postural hypertension, get a simple 12-lead ECG. Okay, 12-lead ECG is there. If the 12-lead ECG shows the normal, then what are the things to be done? So if the patient is able to mobilize, you can go for exercise stress test and nuclear perfusion scan and stress echocardiography. If the patient is unable to mobilize, you can do the pharmacological stress echo, nuclear perfusion scan, and CT coronary angiogram. On the other side, if the patient have got an abnormal ECG, like LBBB or STT changes, you can ask for exercise stress echo or pharmacological nuclear perfusion scan. Ultimately, if these things are there, still you have to confirm, directly you can go for coronary angiogram, if needed, angioplasty and stenting. So ladies and gentlemen, to summarize my talk, these are the few important points to be noted. So patients with diabetes are at high risk of mortality from CVD. Given this group of patients often present with atypical symptoms and silent ischemia, traditional recommendations for screening in symptomatic individuals may not be applicable. National guidelines recommend incorporation of cardiovascular risk score in risk stratification. Risk factor scores have arguably suboptimal performance when used in isolation and have not been extensively validated. Additionally, to date, such clinical signs as erectile dysfunction or autonomic neuropathy have not been incorporated into cardiovascular risk prediction models, though it is well recognized that these pathologies represent underlying cardiac disease. Use of combination of risk score and relevant clinical findings in the overall assessment of cardiovascular risk. The algorithm presented may provide treating clinician with various clues to prompt further investigation with provocative testing. There is an ongoing need for re-evaluation of guidelines for screening in this high-risk patient group. Thank you for your patience hearing.